Thanks, Arup. So my talk is on incorporating cutting-edge technology into IOL power calculation. In a WhatsApp group, you always end up seeing these kind of messages. I performed an uneventful phaco with a multifocal lens 20 days ago. Unfortunately, the patient has a residual error of 0.75 or 1 diopter, and the patient is not happy. Now, what is the best option? So we see these messages, and it troubles all of us. In a 2023 CRST interview, Professor Doug Koch said that 90% accuracy is probably our ceiling, and patients must be informed that they have a 1 in 10 chance of having a residual refractive error. The technology that we use can be high-tech, but should be appropriate if you're working in a small rural center, or whether we are working in a large corporate hospital with a lot of funding. We can choose to have high-tech options that is low cost or which is expensive. The first step to get good power outcomes is to optimize the cornea and the tear film, and we have some low-cost options like the IOL size. This particular instrument is actually a warmer which heats up the lid, and it's got safety controls inside, and it was designed by an AIOS alumni. We also had to do lid scrubs and use any preservative-free artificial tears 4 times a day. We also have very high-tech options for this, like upgrading the lid margins, like intensive pulse therapy, like thermal pulsations. So we have high-tech options to optimize the corneal surface. All optical biometers will give accurate axial length values. But the SSOCT-based devices are better in acquiring data from eyes with wide cataracts and hypermature cataracts. In this 2023 article, which compared 4 different optical biometers, the B-scan, the ACU-scan, and the Argos were able to image all the eyes with dense cataracts. Next came the IOL Master and the Anterion, and Pentacam did poorly. Only about 60% of the series of eyes could acquire a proper axial length. In the days when we did manual keratometry, when we had a cornea like this, we know that we had to ask him to blink or we have to optimize the cornea. But the older versions of optical biometers and the older versions of IOL Master cannot differentiate a pristine cornea and a cornea with a poor tear film. But the newer versions can. Can you make out the difference between the picture on the right and the picture on the left? If you see one, you have split circles and you have distorted circles. So when the operator sees these kind of dots on the review panel, he has to retake this particular one while you can use the data from the right eye. The OCT also gives you an OCT image of the lens. We all deal with posterior polar cataracts, and we are worried that we're going to have a problem intraoperatively. But when you see a beautiful posterior capsule like the second and the third, we don't have to discuss the risk of PCR with these patients because they'll have a routine intraoperative procedure. This is an IOL Master lens picture from a person with a posterior polar cataract where you can see a nice bulge of the posterior capsule. So this patient probably will have to have the discussion about increased risk during surgery. This patient developed a PCR. He came with a white cataract. He gave history of having multiple anti-VEGF injections. You can see a beautiful tear in the posterior capsule. So preoperatively, through this white cataract, the IOL Master 700 could pick up a torn posterior capsule. In 2024 July, there's a compilation of IOL power calculation formula and when to utilize them in iWiki, and it made our work much easier. So for all spherical IOL power calculations, please use Barrett Universal 2 or a Kane formula. Among the various toric calculators, Kane toric and Barrett toric give you the best results. In cornea with prior refractive surgery, please choose Barrett's TrueK formula. And if you have access to the Alcon Varion or Zeiss Callisto, you can do markerless overlay to improve the location and shape of your rexus, and you can also do axis marking with that. Using a topography is also important because it will help you to pick up a keratoconus like this. Otherwise, you will end up treating the central part with a 2.38 cylinder and miss out the much larger cylinder that shows up, a 6-cylinder, when the pupil dilates. So photopic and mesopic powers will differ in eyes with irregular corneas. In future, we believe that wearable simulators will give a patient an experience of vision with various IOLs before we implant them. So this is a Vivo Optica from B Vision, And in this, the patient data is captured on top left, and then the computer works on it. And using adaptive optics, you have a wearable heads-up device. It gives you the simulation of what you will see with an EDOF lens or with a bifocal lens or a trifocal lens or with monovision. So you can give an experience of how the patient is going to see after surgery by using these advanced machines. But we had to think about this: expensive equipment, expensive maintenance, expensive replacement parts. This particular doctor purchased an IOL Master 5 years ago, and he had to change the motherboard last year, so he ended up paying an extra 6 lakhs, and currently he's paying an AMC of 2 lakhs. So over a 10-year period, these equipment will cost you 60 lakhs plus, and over your lifetime, you're going to spend more than 1 crore rupees on just any one of this advanced equipment. Our revenue stream is uncertain with our insurance payouts decreasing. So although we want the best outcomes for our patients, we had to make sure we don't get diabetes, hypertension, or ischemic heart disease. We should not pay a price for the better outcomes that we aim for our patients. So incorporating high-tech solutions can be painless if you choose low-cost solutions like using an online Barrett's or Kane formula, which is applicable to all. The high-cost solutions should be used only when they are appropriate. Thank you.
This has to be switched on? Yeah. So thanks a lot, Ramesh, for a wonderful